All right. Hello and welcome, everyone. We are going to go ahead and get started on our acute kidney injury and chronic kidney disease lecture. This lecture is actually a very important one and one that we're going to take our time going through. We have 61 slides today. Let's go ahead and get started. So, as usual, I'm not going to stop on the objectives. You're more than welcome to read them. If you need a refresher on the anatomy, please come visit this slide. Okay, you can go through all the structures again. I'm not going to do that. Major functions of the kidney. You should definitely know that your kidney is the waste removal plant of your entire body, but it's also responsible for maintaining fluid balance and electrolyte balance as well. So we're going to talk about that. We're going to talk about some other things. If I ever ask you, what are functions of the kidney? Well, there's a lot of things. It regulates blood pressure. Well, how so? The RAS system. Also, sodium retention, fluid retention, albumin, red blood cell production, vitamin D activation, prostaglandin synthesis, and acid base balance due to its ability to regulate bicarbonate or HCO3. Okay. So, what do we have? We have the nephron. And now this is kind of a small picture. I can't blow it up any more than this, but you do have the ability to blow it up if you'd like. So we have what's called tubular reabsorption, and we have what's called tubular secretion. So what happens is essentially we have an artery, okay, it's coming off the aorta, coming into the renal art, coming into the oh boy, coming into the kidney via the renal artery. There it is. And then we're going to break off into arterioles. These arterioles will come into what's called Bowman's capsule, where you will find a network of tubules and pathways known as the glomerulus. Okay, the glomerulus is then responsible for pulling in. It's like a filtration system where we start with a big broad filter that captures everything, and then we start going through a series of smaller tubules, and we collect more and more as we go, and I'll explain in a moment. So essentially, we go from the glomerulus. The glomerulus passes it into what is known as the proximal tubule. The proximal tubule then descends into the loop of Henle. All right, and our loop of Henle goes down, then comes back up, and then we are coming up into the distal tubule. So this is the descending loop of Henle. We have the ascending loop of Henle on the backside, coming into the distal tubule, which is then it goes to the collecting duct. And the collecting duct then is connected to the renal pelvis. The renal pelvis is connected to the ureter, left or right. Then the ureter is connected to the bladder to the urethra, and then to the outside world. Boom. Ta-da! You know everything. Okay. So and this is just a brief overview of what the proximal tubule is responsible for. So the proximal tubule is responsible for regulation via sodium potassium channels, and it regulates glucose, amino acids, bicarb, water, chloride. It regulates all sorts of stuff. And what essentially is happening in the early tubule or early proximal tubule is that we're trying to get into the interstitial space sodium, glucose. We're trying to get potassium and hydrogen into the tubule. We're trying to get water out of the tubule, and we're trying to keep those things. We're trying to excrete the waste that is hydrogen, some chloride, some sodium that is excess. The proximal tubule is responsible for up to 2/3 of water and electrolyte reabsorption. Okay. Additionally, it's responsible for filtering glucose, amino acids, proteins, and vitamins from the filtrate into the interstitium that is over here. So keep that in mind. The distal tubule and collecting ducts, distal convoluted tubule, what do we reabsorb? Sodium, potassium, calcium, and phosphate. Okay. You definitely need to know that. Proximal tubule, come back up one more time. We're reabsorbing 2/3, and we're reabsorbing sodium. We're absorbing glucose, amino acids, bicarb, and water. Whereas in the distal tubule, we're reabsorbing sodium, potassium, calcium, phosphate. Okay. And the thing about it is, and something important to note, is wherever sodium goes, water likes to follow. All right. Additionally, antidiuretic hormone is the regulatory hormone in charge and responsible for telling the kidneys, hey, I don't need this fluid, go ahead and get rid of it, or no, I need this fluid, let's keep it. So when antidiuretic hormone is present, we retain fluid. We decrease urine output, we keep that, we hold on to that fluid, and we tend to hold on to some sodium as well. In the absence of ADH or antidiuretic hormone, we're going to go ahead and increase urine output and increase urination. Okay. So, but anyway, sodium reabsorbed with aldosterone present. The more aldosterone, the more sodium is reabsorbed. We've talked about the RAS system, the renin-angiotensin system, the aldosterone, and how these effects on the body not only vasoconstrict, angiotensin 1 and 2 are potent vasoconstrictors, but also how aldosterone is responsible not only for some degree of vasoconstriction, but fluid retention. I'm going to also point out and put a star on this one. Another name for aldosterone is vasopressin, and we give vasopressin in the hospital to regulate blood pressures in patients that are either in a state of shock or are currently hemorrhaging. So, fun facts. But anyway, so once it's gone through the distal convoluted tubule, the filtrate we have left is hypoosmotic. The collecting duct, so we definitely need to know the collecting duct, okay? In the distal tubule, the reabsorption to the distal tubule, or similar to the distal tubule, H2O is reabsorbed if ADH is present, and then we have our bicarb and our hydrogen, which is also reabsorbed, okay? Or it's excreted to increase the acidity of urine. So I'll point out that hydrogen is the acid there, bicarb is the base. So if I have acidic urine, I'm going to, and I want less acidity, pull more hydrogen out, which is almost never going to happen, and we keep more bicarb in. Okay, whereas the vice versa is true. If my urine's not acidic enough, I need to increase the acidity of the urine. We're going to have less reabsorption of hydrogen, more reabsorption of bicarb. Okay, we leave with a hyper or hypoosmotic to meet whatever the body's needs might be. Now, I'm going to point out the glomerular filtration rate is a very important number that we love to overlook. We're just like, BUN and creatinine, it's fine. Okay. And while BUN and creatinine are incredibly valuable, they are not the only things that I want to pay attention to and not the only things I want to monitor. So when I talk about GFR, glomerular filtration rate, I want a normal rate of 125 mLs per minute. Okay. And what that means is that every minute, my glomerular filtration rate throughout my entire body, my total volume per minute is 125 mLs of fluid. All right. So now, I'll admit, we obviously aren't going to pee. And, if we did the math on this, it's like over 8,000 mLs an hour. We're not urinating out 8,000 mLs an hour. What's happening is that we're filtering our blood supply multiple times over and dictating what does and does not need to be reabsorbed. 99% of it we do reabsorb. 1%, let's urinate it out. Positive pressure gradients, process fluids and solutes from blood depends on glomerular blood flow, whether or not there's obstructions or high pressure. Pressure in the Bowman's capsule is very crucial. Plasma and oncotic pressure. Now, I'm going to point out one of the biggest culprits of chronic kidney disease is persistent states of uncontrolled hypertension. The reason being is that as these persistent states occur, we actually damage the capillary beds inside of the Bowman's capsule in the filtration system there. We damage the capillary beds and we actually decrease their ability to filter and to pass fluid through them. And if we decrease that fluid and decrease that passing and we decrease blood flow to the kidney overall, then we're going to decrease the functionality of the kidney as well. Tubular reabsorption, we've already talked about, but I'll say it again. Movement of substance from the filtrate into the peritubular capillaries or the blood. So, in other words, what I would like to keep. Tubular secretion, what I don't want to keep, is transportation of substances from the peritubular capillaries into the tubules for eventual excretion in the form of urine, specifically potassium, hydrogen, and any drugs or waste. Urine flow, I've already talked about that. But what I will say is this: your entire blood volume is filtered 60 to 70 times per day. Please know that. Please know that. Of all that urine that we filter, the 180 to 240 mLs of all that, we generally only secrete about 1 to 2 liters per day. Your average urine output is typically about 0.5 mLs per kilogram per hour. So if I'm 100 kilograms and I calculate by zero point 0.5, that would be roughly 50 mLs an hour is my lowest minimum threshold I want to see slash normal. Okay. Oh, I forgot one last thing. GFR, one of the biggest peeves I have is people look at the GFR and they're like, oh, no, that's fine. Everything's good. However, the thing is that the GFR is considered normal all the way down to 60. And that's not actually normal. What that is an indicator of the ability of the glomerulus to continually filter. and how fast it filters. But if we've already gone down to 60, we've cut the glomerular filtration rate and capabilities in half. So if you're sitting on the front doorstep of 60, 65, you're not in a good place. We're like, oh, it's normal, it's fine. No, actually, it's not fine. It's acceptable, would be a better term, but it is not fine. Any degradation from the range of 120 to 125 is considered to be a negative in that I have decreased functionality. 60 just happens to be the threshold at which I have a substantial problem now that we actually need to address. Okay. So, fun facts there. Talked about that. So let's talk about renal function. I definitely need you to know, if you don't already, please submit to memory, normal numbers for creatinine 0.6 to 1.2, BUN 10 to 20. The ratio should always be 10 to 1. GFR greater than 60. I'm not going to do calculated creatinine clearance, and I'm not going to do sodium. And that's what that is. Fractionally, I think it's not expired, expirated. No, it's sodium. I can't remember the exact E there, but so it's what you're essentially getting rid of in your urine. So I need you to know those numbers. And then we have our serum osmolality. Not as important. Something I'm not really going to be too worried about here. Creatinine, BUN, ratio, and GFR. Diagnostic tests. We're going to do some imaging. If I suspect you have an acute or chronic injury, we can do what's called a KUB X-ray, kidneys, ureter, bladder, and we actually do. We start at the retroperitoneal area region, and we work our way down all the way to the bladder and urethra. We have the IVP, intravenous pyelogram. I'll show you one of those in a second. The ultrasound of the kidneys, I'll show you that as well. And then the renal angiography also will show you that as well. Essentially, the issues that the kidney is going to have come in the form of either pre-renal, intrarenal, or post-renal. And so essentially what we would be doing is using these diagnostics to assess that, the pre, the internal, and the post. So we'll talk about those just shortly. Here's a good ultrasound. It's actually almost too good an ultrasound to even believe. You can see some of the vasculature, some of the collecting ducts here, the renal pelvis, the blood flow. I don't expect you to know what these are. Oh, I don't even know what they all are. This is a gorgeous CT angiography, and you can very, very clearly see that the dye lit everything up like a Christmas tree. You can see the blood flow, you can see the arteries, the veins, you can see everything. Now, I'm going to point out, if you have impaired kidneys or acute kidney injury or chronic kidney injury, we may not want to give you contrast. Why is that? Because the iodide contrast is typically very hard on the kidneys. We'll talk about that more here in just a minute. Okay, but so this is something you want to think about right here. This is a great representation of what a CT angio would look like to identify any abnormalities in terms of growth, structure, or impaired blood flow to a region. Renal angiography is just like it would be for an angiogram for a heart, a cardiac angiogram, where they essentially look at the blood vessels in the heart to identify any pathways where there is obstructed blood flow. Okay, so what we'd be looking for is we'd go in with the and then you'll forgive me the exact tool, the angio camera. We go in with that and we actually inject the dye just up here superior to the entrance of the renal artery, and then we take a picture. And that picture, if we see like right here, if this is all narrow and constricted, just like it would be in a blocked coronary artery, we can see that. Sometimes they can stent them. Sometimes they don't need to because it's too small of a vessel. But this allows us to see if there's impaired blood flow due to a clot, a physical obstruction, or sclerotic buildup. Okay, so let's talk about the definition of acute kidney injury. Acute kidney injuries occur suddenly in the acute care setting or suddenly due to medical injury or traumatic injury. Okay, so what happens is we now have an imbalance in fluid and electrolytes and acid base, which is secondary to decreased glomerular filtration rate. I can't filter properly. What's going to happen? I'm going to get a backup. What am I going to get a backup of? Potassium and other substances. So kind of a big deal there. Affects up to 20%. 20 to 40% of all critical care patients. Mortality can be pretty substantial. Now, I don't like that it gives you 15 to 60%. I'm not a fan of this. Typically, it really depends on how severe the patient gets before seeking treatment, one, and two, how early we initiate forms of filtration or pseudo filtration, such as hemodialysis. Okay. So if we have a patient and they come in for acute kidney injury and they need it and they're not making urine for days at a time, 24 hours later, we're already examining the potential need for hemodialysis. Why? Because honestly, it'd be like you didn't take the trash cans out for a year. You'd have some garbage buildup. Well, that 1 year, all it takes is about 24 to 48 hours to get that kind of buildup inside your body of waste products, of excess hydrogen ions, of excess potassium, of excess fluid, etc. So we got to get that out of your body. Only one real way out, and that's the filtration system that is your kidneys. So, ah, this is the rifle criteria for AKI. I definitely would like you to know what rifle stands for. Acute kidney injury, we look at risk, injury, failure, loss, and any end stage renal disease, and we'll get to that in a second. But essentially, acute stage is the first four, RIFL. Okay. And so what we're looking at is the onset. All right, I took damage, I took an injury, medical or trauma. My creatinine's up by 1.5%, GFR down by 25 from baseline. Okay, from last known or from normal. No, you can also do from normal. Injury, second stage, creatinine's up by 2, GFR down by 50. We are now in the official injury stage. Failure, third stage, creatinine by 3, GFR down by 75%, or creatinine above 4. Now we are in straight up kidney failure, could be acute, and we are acute in this stage. Loss of functionality altogether is the fourth stage, which is persistent acute kidney failure. Now we are over 4 weeks. Okay. Anything below the 4 weeks falls into the category of risk, injury, or failure. When we're discussing something that goes past 4 weeks, we're looking at loss. And if we're looking at loss, we're potentially looking at being hemodialysis dependent, and we're going to have to look forward into the future a little bit and assess whether or not we're going to have end stage kidney disease. But we can't assess that for up to 3 months. So if we make it from that 4 week mark on loss all the way up to that that end stage kidney disease, and we are now 3 months later, the assumption can safely be made: I do not have return of function. I do not have, any kind of functionality in terms of my ability to create urine. So now I'm going to go ahead and I'm going to be classified as an ESRD, or end stage renal disease patient. So please keep that in mind. These are the criteria. I definitely need you to know them. Move past that. Actually, I will just briefly touch on this really quick. The Acute Kidney Injury Network is a network that specializes in terms of the development and implementation of criteria for identifying acute kidney injury. The diagnosis of AKI is only considered after you have rehydrated your patients and excluded all obstructionary issues. So for this particular an example, I'm going to utilize a patient that is dehydrated and has kidney stones. Or even potentially, BPH, they have a prostate obstruction. So if we rule out that the cause for the decrease in urine is a lack of fluid to even filter, all right, we rehydrate you, still no urine. Okay, well, next I'm considering an obstruction. Okay, where would I look? Well, first we're going to look in your urethra, the bladder. We're going to look in men with the prostate. We're going to look at any kidney stones, renal calculi, flank pain, etc. We're going to look at any physical blockages, obstructions. If we can rule If we can rule all of those out, then we would go ahead and be leaning into the criteria for an acute kidney injury. So the thing about it is the AKIN system, rather than the rifle system, relies on serum creatinine and not the GFR. So serum creatinine is important to identify, but the AKIN system solely uses that as its criteria for defining acute kidney injury. So we don't even need a baseline serum creatinine, but what you would actually have to have is two serum creatinine levels drawn in the last 48 hours. So, and what we're then looking at from there is if we have a sudden decrease within that 48 hours of renal function as resulted by the serum level of creatinine, okay, at least 0.3 milligrams per deciliter or by a percentage of 50% or more, or 1.5 times base value, or decrease in the urine output documented with oliguria less than zero point 0.5 milliliters per kilogram per hour, more than 6 hours, then you have met the criteria and essential functionality for having acute kidney injury. So there's two different systems. I prefer you to know rifle, I just want you to be aware of what the AKIN is and why it exists. Here is a comparison of the two. I do not need you to know them super in depth. I definitely would like you to at least know urine output decrease over 5 hours, less than 0.5 milligrams per kilogram per hour. 12 hours, we're in injury now, still less than 0.5 milligrams per kilogram per hour. Over 24 hours, less than 0.3 mLs per kilogram per hour. So we actually lower the threshold. And then after that point, you are in acute kidney failure, defined as acute kidney injury. Now, to understand kidney injury in depth, you need to understand pre-renal, intrarenal, and post-renal injury modalities. So in this instance, the bulk of pre-renal injuries, 70% of all injuries, are what's responsible for the AKI, 25% intra, and 5 or less post-renal. Perfect. I don't know why this picture is sideways. I've never understood that. Examples of pre-renal, please write these down. Sudden and severe drop in blood pressure due to shock, exsanguination, or hemorrhage elsewhere in the body, or dehydration. Interruption of blood flow from the kidneys due to severe injury or illness, or potentially a physical obstruction. Okay, so if the heart's damaged, you're given CHF, you can also have the same issue, impaired blood flow to the kidneys. Persistent hypertension is another one. Okay, so please keep that in the back of your mind. Intrarenal, direct damage to the kidneys, resultant as inflammation, toxins, drugs, infection, and reduced blood supply. Postrenal, sudden obstruction of urine flow due to enlarged prostate, kidney stones, bladder, tumor, or injury. In men, prostate urethra is there. Excuse me. Okay, so if I ask you to define for me examples of pre-renal failure, intrarenal failure, and post-renal causes, you should be able to very easily cite these, at least 3 for each. Pre-renal etiologies, and I just mentioned both of them, hemorrhage and dehydration, resultant in hemorrhagic shock. Prolonged hypotension due to sepsis, vasodilation, anaphylaxis, or any other form of distributive shock, such as psychogenic shock or neurogenic shock. Okay. Either way, the longer I go through a state of having decreased cardiac output, I therefore am going to have decreased renal perfusion. Decreased renal perfusion equals a decrease in functionality. We need to figure out pre-renal, intrarenal, post-renal. So let's talk about some of the intrarenal. Okay, they're the intrarenal causes of failure. One of them, and when I say endogenous versus exogenous, endogenous can be considered internal causes, exogenous could be considered external causes. So please keep that in mind. All right, continuing. But when I say endogenous, we can refer to and talk about stuff that occurs inside the body. One of the most common causes of acute kidney injury that we see in the acute care setting, in the inpatient setting, is rhabdomyolysis. Rhabdomyolysis is a condition that can occur for one of a couple reasons. One, you worked out way too hard at the gym for the first time in a long time. You damaged a bunch of muscles and you tore them, and now all the little particles and proteins are breaking down. And they're big particles. Proteins are big molecules. Okay, I shouldn't say molecules, they're big compounds. And when they hit the filtration system, sometimes they clog it up and back it up, resulting in some severe kidney injury in terms of acute, but usually you can recover from it. Other causes of rhabdomyolysis are any kind of muscle wasting, muscle destruction, or any other toxins or substances that break down muscle in mass and cause all these proteins to be secreted into filtration. Tumor lysis syndrome is such condition where we see the muscle wasting, where you have the muscle breaking up and breaking down, and then potentially the tumor itself breaking down and distributing its products, whether it's toxins, waste, or just cellular components, into the bloodstream where it doesn't belong in large quantities, resulting in the kidneys getting injured and getting backed up. So we definitely need to talk about infection. Okay, and infection is going to be like glomerular, excuse me, glomerulonephritis or pyelonephritis or interstitial nephritis. Anytime the kidneys themselves are under attack by a bacterial infection, and the most common cause of any renal infection is going to stem from typically a UTI that has gone way too far. UTI up the urethra to the bladder, ureters, and subsequently to the kidneys results in pyelonephritis. Okay. Additionally, we could also have an internal, like a blood infection, resulting in glomerulonephritis. Either one is bad. We're impairing the functionality of the tissue. It's under attack. It's dying. It's being damaged. It's swelling. All bad. Ischemia from pre-renal to intrarenal. Perfect example of that would just be a blood flow issue. It's either going to be a clot, an obstruction, or it's going to be some variation of um, anything in the way, sclerotic buildup or calcifications, all those. And then lastly, exogenic toxins, things that are injected outside the world, outside body, into the body, into the bloodstream. Typically radio contrast dye or iodide dyes, nephrotoxic medications. Vancomycin is one that you can put really high on that particular list. And that's why we do vancotroughs. So stuff like that would definitely be up for consideration. So, stuff to think about. If I ask you for intrarenal causes, this would be that list. Postrenal, pretty simple actually, and almost all of them fall under mechanical in nature. What I mean by mechanical is that it's going to be a physical obstruction, not in the actual blood flow path, but the urine path. So either the urethras themselves are blocked by, or excuse me, the ureters themselves are blocked by like kidney stones, and I have seen that, or maybe the bladder is damaged, injured, went through some trauma, has scar tissue, etc. Okay. Maybe the urethra is damaged or swollen or inflamed or obstructed. Okay. The prostate. The list just keeps going. If there's a physical obstruction, this is where we're going to go ahead and get urology involved, versus a nephrologist. So, some stuff to think about. Different causes equal different doctors. We don't really need to go into this too much. Ischemic is just how it sounds. Clot, lack of blood flow, lack of perfusion, related to hypotension, bulimia, tubular cell damage, and cast formation results in impaired endothelial function. Because remember, all those tubules have cells lining them, and if they get damaged, they are impaired. Toxic injury caused by drug or chemical, contrast dye is common. Serum creatinine elevates 48 to 72 hours after the exam. Put a star next to that, please. That's a big one. If you're going to see a rise in serum creatinine related to iodide injury or contrast injury, it will be roughly 2 to 3 days after. Peak is 3 to 5. Return to baseline should be in another 3 to 5 days. 10 days total at maximum. Kidney dysfunction can resolve or persist. I'd say in most instances it is resolved, but the risk does exist that it could continue on potentially. Metabolic acidosis. All right, so all of a sudden, I'm not excreting waste products any longer. I have an excess buildup of anions or hydrogen molecules in this case. We call them free radicals a lot. Compensatory response. What does it do? I'm going to get a longer PR interval, prolonged QRS, and I'm going to have a peaked or taller T wave. Why? I'm in a state of metabolic acidosis. If I ask you for ECG changes related to metabolic acidosis, this right here is exactly what I expect you to give me. Longer PR interval, prolonged QRS, peak T wave. That's what I want to hear. Electrolyte abnormalities. If I'm holding on to my urine, not excreting it, not making it, I'm going to be hyperkalemic, hyperphosphatic, or phosphatemic, hyperchloremic, hypocalcemic, because again, I'm not reabsorbing, I'm not getting more, and hypoalbumemic. So, fun facts. I need more albumin. Ooh. Urine sodium, inaccurate in presence of diuretics. Yes. Prerenal, low. Intrarenal, high. All right. So these are the changes that would take place if I had AKI, decreased urine output, and decreased filtration. AKI nursing diagnosis, not concerned. Moving forward. Causes of chronic. So now we're going to go ahead and we're going to shift gears pretty hard. We just went from the AKI realm into the chronic kidney failure realm. Okay, this is a big shift. So what we have here is the common causes of chronic kidney failure being volume overload, uremia, and I'll show you that one. That one's kind of an interesting one. Catabolism, anemia, cardiovascular events such as MI or stroke, bone demineralization that occurs commonly as you get older with age or during menopausal phases, infection, sepsis, pericarditis, and depression. Okay, so please keep all those in mind. So anyhow, let's move on and we'll talk about uremia, also known as azotemia. So the pathophysiology essentially is that we have had now a chronic kidney injury and we no longer have the ability to excrete the uric acid that is in our body or nitrogenous products. So what we do is we hold on to all of it. So how this sometimes manifests is not only a uremic state within the blood itself, but we actually begin to develop, and when we have high concentrations and amounts, we actually begin to develop a layer on the surface of the skin and it looks very much like this right here, where you actually build up like a frost layer. Almost looks like salt. And this can be anywhere on the body, but it's predominantly located in the armpits, the groin, the neck, and the face. And what you see is a combination of not only just the frost itself, but a clinical manifestation of nausea, vomiting, anorexia, a metallic taste or in the mouth, pruritus, and then the uremic frost covering the surface of the skin. So what this is, again, an excess buildup of uric acid, creatinine, and nitrogenous products in the bloodstream. Please make sure you know that. CKD stats. Number of people dying from CKD every year has risen from 5 million to 10 million. That actually looks like it's numbers from 2014. These look like some pretty old numbers. The number is actually probably closer to about 16 million a year now worldwide. Excuse me. Roughly 660,000 Americans have reached ESRD requiring dialysis or transplantation. That number is also actually up. We have almost broken the 1 million mark as of 2022. This has led to a major public health and economic burden. That's an understatement. The absolute staggering results of increased CKD cases is horrid. Um, I mean, aside from the fact that a lot of these patients either have hypertensive issues, diabetic issues, but now on top of it, they're hemodialysis patients in the more severe cases because you can't do PD, peritoneal dialysis. What ends up happening is they go to dialysis, 3 days a week, Monday, Wednesday, Friday, or, Tuesday, Thursday, Saturday. Well, it's really hard to find a job that's willing to work around that, one. And two, even if you can, it's really hard to go find a job that isn't so physical because even though you're going through hemodialysis, you have essentially peaks and valleys. You have these periods where right after dialysis, you're starting to feel better, doing good, really good, really good. Oh man, I feel a little bit better. Okay, I got some of that toxins, some of that waste out. And then we go through that next day, we build it back up, build back up, build back up, build back up. And then we go into dialysis again. And so there's peaks and valleys in the sense that we go through this, overabundance of uric acid buildup, creatinine, etc. And then we come down out of that every time we get dialysis. The problem with that is many people don't have jobs, so they rely on disability, they rely on Medicare, and they use those tax dollars essentially in the form of federally provided insurance monies. And just the cost of dialysis alone, no other treatments by themselves are over $160,000 per year per patient. And that's on the low end. 160K per year, not including any other medical management, blood pressure management, medications, doctor's appointments, visits, nothing. And that's paid for by Medicare. Okay, so it's incredibly, incredibly expensive when you have patients on hemodialysis. So CKD is actually a pretty substantial issue. Now, the stages of CKD can be ranked 1 through 5. They're very easy to classify. Any GFR that is going to be less than 60. Actually, no, that's greater than 90. I apologize. Is going to be stage 1. I don't understand that one. Essentially, I think the focus there is kidney damage. I never see, by the way, just fun fact, we never use the rifle system, the AKIN system, or the CKD stages in the hospital for the most part. And normally, if we do see the stages in the hospital, we don't see 1. We don't see number 2. We see 3 and 4 pretty regularly. So, but anyway, kidney damage with a GFR greater than 90. Mild damage with a GFR 60 to 89. Moderate with a GFR of 30 to 59, severe with a GFR 15 to 29, and kidney failure outright, ESKD or ESRD, stage 5, can be classified as zero output potentially. And these patients are the ones that you commonly hear referred to as anuric. Okay, so just be aware of that. Just fun fact. Yeah, it's good to know that there is some renal protection diabetic medications such as SGL2 inhibitors, SGLT2, excuse me. But yeah, I'm not touching on that. All right, who's that? Under risk patients or at risk patients, underlying chronic kidney disease. 50% of patients are unaware they even have kidney disease until they go to their doctor and find out, or until they're almost stage 4. So they'll be like, oh yeah, I noticed my urine output had decreased, and I just went, oh no, it's fine. Concentrated, smelly urine. Before you know it, they're in ESRD stage 3, stage 4, just like that. Older age, we're going to be greater than 60 years of age in 25% of all cases related to diabetes and hypertension. I said it earlier. The direct comorbidities and increased risk factors for these patients lie with diabetes and lie with hypertension persistent states. Multi-organ involvement, heart failure, respiratory failure, and liver disease, very common. AKI can lead to ARDS, but chronic kidney failure can lead to multi-organ stress at all times. This is something that's kind of important to pay attention to, and you need to be aware of it. At-risk patients, rhabdo patients, shock patients, yes, contrast patients, induced. So with the CKD patients, we're worried about contrast-induced nephropathy or nephopathy. No, it's nephropathy. Excuse that. Contrast-induced nephropathy, CIN. 1% of patients will require dialysis, and believe it or not, increased mortality at 5 years. So a substantial drop off just due to giving contrast. Now, there are some ways that we can protect the kidneys. There are medications we can give, Mucomist, etc. We can also make sure that they get adequate hydration and flushes if they are not an ESRD patient. If I have a patient, normal patient, every day, Joe Blow Schmo, who needs to have a test done, we're going to give him contrast dye. He ingests it, digests it, the whole thing goes, all right, cool, or they inject it and the kidneys have to filter it, we're going to give a bolus of fluid, typically in the range of typically 500, 500 is on the low end, to 1,000, depending on the size of the patient and the dose of medication used. CAUTIs, or catheter-associated UTIs. This is why aseptic technique is so important. Catheter care. People don't like doing this stuff, but you got to do it. Like, I don't know what you expect. You wipe yourself every time you go to the bathroom. You got a patient sitting there with a catheter inside their urethra from the outside world all day long. You don't think bacteria is propagating in the vaginal canal. You don't think bacteria is propagating in the foreskin or the tissues around the glands. It is. So clean, sterilize, wipe down, and then evaluate needs daily. Do not, and geez, if there ever was a pet peeve of mine, I hate this. I don't know why nurses do this, but you'll see nurses break the seals on Foley catheters. Don't frickin' do that. There is almost no excuse to do that. And people are like, oh, well, you got to flush it out. You, you, you can. Almost all brand new Foleys come with an additional means or alternative means of back flushing the Foley without breaking the sterile field. Do not break that field, or if you're going to, you break it, you sterilize, and you immediately replace the entire Foley. That's how that should be done. Big deal. I hate this. There's no excuse for this. All right, preventative awareness. Yes. How to manage AKI. What are we going to do? We're going to be aware, electrolyte balance. You'll see a common one, and I really like this. You're going to see like dopamine occasionally for your chronic kidney disease patients when they need a little additional support. But that is not the case with your AKI patients. What we're after with our AKI patients is typically a fluid resuscitation or fluid replacement. So if they can't handle excess fluid, we're going to give small amounts of fluids, typically colloids or crystalloids, albumin for example. We're not going to give them NS. We're not going to be giving them, we may do like a half NS. We're going to have fluid removal, maybe in the form of dialysis, but what we're going to go after is we're going to do colloids, crystalloids, and diuretics is the key here. So you're going to see anywhere between 40 to 80 of Lasix, once or twice a day. Typically 40 BID is a good place to start if we're trying to kick fire the kidneys again. You may see Bumex, 1 to 2 milligrams BID, and then additionally, again, the albumin and maybe a little bit of continuous fluid therapy on top of that at 100 an hour, 75 an hour. Just depends on kind of where you're at in your AKI and whether or not you need a full fluid volume restriction. But dopamine. We do not use dopamine in the medical management of AKI. In the instance where you are in a place where you're under acute attack or chronic attack, and sometimes that is needed, you will see nephrologists order like 2 mics per kilogram per minute of dopamine. And when you see that, what they're ordering is just essentially a slight increase in cardiac output to perfuse the kidneys adequately during a state of hypoperfusion. Fun facts. All right, let's talk about renal replacement therapy, also known as CRRT, continuous renal replacement therapy. We do not have this accessible at Desert Valley, Victor Valley, St. Mary's, or Barstow. I do believe that San Antonio does have this, and all of your major hospitals down the hill also have this. Moving on, sorry, my apologies. So anyway, what we're after here is whether or not we have the indications, and the indications are A, E, I, O, U. And now I need you to know this. Please put a star next to it. If your pH is lower than 7.25 and you are acidotic, you are a candidate. If your electrolytes are out of whack, hyperkalemic, hyperphosphatemic, and hypermagnesiemic, we're going to above 4, really high, really, really high. We're going to go ahead and consider this. Ingestion of salt, so salicylates, alcohols, lithium, and theophylline. So overdoses essentially of these, okay, or excess of these. Overload volumes such as CHF, pulmonary edema. By the way, it works wonderful for these patients, very, very well. But unfortunately, we don't have the access to CRRT everywhere you go. And then lastly, uremic complications. So alterations in mental status, pericarditis, and bleeding and platelet dysfunction. A, E, I, O, U. If you fall into these categories, then you essentially you qualify for CRRT. Otherwise, in more severe cases, we would be actually looking at internal hemodialysis or indications for actual hemodialysis versus CRRT. So when we talk about, hemodialysis, we're talking about having to bring the machine in the room. We hook you up. We do X amount of hours, try and get X amount of volume. The problem is that you have to remove large quantities of volume at a higher rate. So for your critical patients, this isn't always the best course of action. In fact, many times it's the worst course of action. But when we see these criteria, BUN above 90, serum above 9, hyperkalemic, drug toxicity, extravascular fluid, metabolic acidosis, uremic, pericarditis, GI bleed, changes in mentation, and contraindications to CRT itself, and there's not that many, by the way. But look at all these contraindications down here for hemodialysis in the traditional sense. Hemodynamic instability. You just literally described like 75 to 80% of all my patients in the ICU. So are you telling me my hemodynamic patients that are unstable and on Levophed and keep fluctuating all over the place should not have this? The answer is yes, but we do it all the time anyway because otherwise it's only going to. So a lot of these, cases where they're acidotic, they're only going to get so much worse if we don't intervene and intervene quickly. Inability to anticoagulate and lack of access to circulation. You got to have a catheter. And by that, I mean you either have to have a large bore dual lumen catheter, Quinton or an Ash cath will do the trick as well, or you have to have a tunnel hemodialysis cath inserted by interventional radiology. Alternatively, we look at stents and grafts, which we will cover here in a second, and those are more long-term solutions. Indications, contraindications for CRRT, large fluid volume removal in an, oh, hey, look, hemodynamically unstable patient. That's so big. CRRT is directly indicated for your critical patients because it's so much. It's 10% in terms of being gentle. It is so gentle compared to hemodialysis. And hemodialysis would be violent, aggressive, and that is not the case when it comes to CRRT. So please keep that in mind. Anyway, hypervolemic edematous patients unresponsive to diuretic therapy, patients with multi-organ dysfunction, half of our sepsis patients, well, almost all of our sepsis patients right there. Ease of fluid management in patients requiring large daily fluid volume, replacement for oliguria, administration of total parenteral nutrition, contraindication to hemodialysis and peritoneal dialysis, inability to anticoagulate. Okay. Who doesn't get it? Anybody with a hematocrit greater than 45. I cannot explain that one to you. And terminal illness. Okay. So I'm going to be real with you. If I had my druthers and I could pick, I would definitely pick CRRT for almost all my critical care patients. The problem is a lot of hospitals don't have access to this. And when you are on CRRTT, it requires one-on-one therapy, meaning your nurse is attached to you and you only. So it requires additional resources, and hospitals don't love doing that. Let us move on. We have our short-term accesses, and I've already mentioned a couple of them. Our tunnel cath, our permacath, our Quinton cath, Ash cath, and large bore double lumen catheter. Okay, there is a difference. Long-term vascular access. This is where we have our AV fistulas and AV grafts. I will show you those shortly. But I do want, wink wink shooting star, please remember, I want you to remember that your job as a nurse is to assess every shift the presence of a bruit and a thrill. So how do we do that? Well, it's real simple. We auscultate a bruit, we palpate a thrill. This is a large bore double lumen catheter. Okay. pretty nice big one there. And you can see how big they are. And they go down into the blood vessel, and you hook up to one side to one and one side to the other, and boom, there it is. Here's a tunnel cath or a permacath going under the skin into the subclavian, and he gives you this massive vessel from which to pull blood and to put blood back into. This one, I want you to pay attention. This is a synthetic graft, G-R-A-F-T, an AV graft on the left, a fistula on the right. The graft is intentionally inserted and utilized in patients that need a temporary access and have a fistula on the right that is maturing but has not yet fully matured. Okay, so you'll see over here on the left, we are going into a vein and we are going into an artery as well. Okay, so when we do that, you can see that we can go into the loop there that descends, and we can tap into it with a venous needle and arterial needle, and we're getting blood literally flowing from the artery to the vein. So blood in, blood out, and we're essentially pulling that out of the body and filtering it. Works great. Okay, a temporary access while a fistula matures. A fistula is surgically implanted and is an autogenous fistula in the upper extremity, and usually see them on the left or right upper arm, or maybe even the lower arm a little bit toward the AC. But essentially, the antecubital vein to the brachial artery is connected, and when you do so, you end up with a fistula, an arterial and venous fistula, and then you actually push through the skin and directly into the ports or the vein itself and access it directly. Now, this one is a good thing in that you have a permanent access. It's a bad thing in that the accesses can rupture, they can bleed, they can become very sensitive, they can become incredibly painful, they can scar up, calcify, the list just continues, and you got to be really careful with them. If you bump them, you can damage them pretty badly, actually. CRT, da, 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 da. It's a 24-hour-a-day thing. Continually removes toxins, excess fluid, and I don't. This is inaccurate. Improves survival in some studies. No, it drastically improves survival rates when compared to hemodialysis in critical patients or hemodynamically unstable patients. It's much better of an option. Also, increase renal recovery over IHD. 100% true. Examples of CRT, I'm not going to lie to you. I have no idea what each one of these means, and I'm not going to try and figure it out. But I do understand that we have the access into the arterial access. We're coming in, coming in. We're going to go ahead, hit our heparin, hit our filter, filtering blood, excess toxin and waste, or effluent, and then back to the body. All right, we're hitting the venous return and going back to the heart. It's very much like dialysis. The only difference is we're filtering at a much slower rate. I mean like 30 to 40, 50 an hour, maybe if that. Okay. And when you're in that range and you're pulling so little blood, and you have to have that heparin or the blood will clot. But when you're pulling that blood, essentially you're doing what your kidneys it's the best mimic of what your kidneys already do. Dialysis is not a good mimic. So what are some of our complications that we have during dialysis? Most common, hands down, hypotension, low, and you can go into any ICU and see that. Bleeding, hypothermia, electrolyte imbalance, access dislodgement, infection, and medication adjustments. Okay, if you have a patient who's bleeding, your best friend, if their fistula is ruptured and just pouring blood, put a whole bunch of a whole inch or two thick stack of 4x4s on the top, get a roll of Acrylex, and start wrapping it around as tight as you can get it. Even then, it's not going to want to stop. We have our electrolyte imbalance. Okay, potassium, sodium, magnesium, calcium, we're all changing that out right now. And this is responsibility of the nurse or tech to regulate per doctor order, what kind of things they are taking away and what they are adding back in. And then infection, just look at the site. Is it red? Is it inflamed? Is it swollen? Is it hot at the touch? Is there purulent discharge? We're looking for all that kind of stuff as well. Now, let's talk about one other kind of dialysis, and you definitely need to know what this is. This is peritoneal dialysis. In peritoneal dialysis, we have the posterior of the body, we have the anterior there, you can see it very clearly, and then we have the peritoneal space, which surrounds the liver, the stomach, the visceral peritoneum, which is where the bulk of our, filtration will take place. We have the falciform ligament there in the front, and then you're going to see we actually connect a catheter directly into the abdominal cavity. And the idea is that when this is in the abdominal cavity, it gives us an access port by which to, put solute or dialysate into the patient and also to take it out of the patient. Okay. So in this case, what I'm going to do, and this is how, and this right here, if you forget every time how to do peritoneal dialysis, here's how it's done. This is a sterile and like field. Okay. The cap coming out of the body, we always treat that as sterile. And I mean always. There's part one. Part two, your dialysate. Make sure it's the right one. Confirm it with your MAR. And then also make sure your dialysate is roughly up to room temperature, if not a little bit warmer. And when I say room temp, I don't mean, hey, Bob, I like it 52 at my house. Want to come chill? Because 52 being directly inserted into the vasculature around solid organs or hollow organs is going to cause you to cool very quickly. It's going to cause your muscles to spasm and contract rapidly. Rapid cycle contracting is not something we want in this patient. And those are all bad things. Okay. So I don't want any of those things to happen. So room temp. And then what we're going to do is we're always going to, if you're in the hospital, I'm always going to drain first. This is not how this looks. I almost never have this valve. I have a bag. I have a little breaker right here, breaker down here, and that's it. So I take the cap off. I take the cap off the bag side, insert it sterilely. I'm going to go ahead and unscrew that right there and open it. And then I'm going to crack the valve going to the bottom bag or the drainage bag. Now, I'm going to remind you, this process right here, the entire thing is gravity fed. So they have to sit up at a higher height than what the bag sits at. So typically the bag is on the floor. The dialysate drains out of whatever's in here will drain out of the abdomen and drain down into the bag. Once it's fully drained out and there's no more, and sometimes you got to slosh them around left, right, back, forth, side to side, you can get it and it's all out. You're going ahead and lock that off. Typically put clamps in line and then open your solution bag. Now, typically the solution bags come in volumes of about 2,000 mLs. They can come in more, come in less. 2,000 is the most common. So what you'll see is that 2,000 ml bags have order sets associated with them in the MAR, and it says, hey, drain them, then insert or dwell 1,000 mLs of this fluid, 2.5%, 3.5%, 4%, 1%, etc. Well, some people forget that and they just like open it and let the whole 2000 flow. No. You need to match your orders. It's going to tell you how much the nephrologist wants you to dwell, and you need to adhere to that order. So we're going to go ahead, open the bag, and start the process of draining this into the patient. Now, if it's draining too fast, it may cause discomfort, so you can slow it down or partially control it with a clamp, a Kelly clamp. We partially obstruct the flow, and boom. The Kelly clamp works, decreasing the flow, decreasing cramping, and decreasing discomfort. And it may be a little uncomfortable. They'll know best. And if it's somebody that's confident enough, sometimes I even let them do it themselves. Okay. After draining the ordered amount into them, we're going to clamp it off. We're going to close or screw shut their seal. I'm going to take a sterile, not seen in this picture, a sterile iodine cap, pull it out of its package, take the tubing, pull it off, and then clamp it. Or clamp and put the cap on to sterilize the whole system. We typically do this about every 4 hours. In some instances, you will see patients requiring Q 1 hour, Q 80 minutes, Q 90 minutes. It just depends on how sick they really are. So, who do we use it with? CKD. There's exactly what it looks like right there. Okay. Very low frequency of use. It requires a lot of responsibility on the part of the patient, and I mean a lot, like a lot of maturity. It's not easy to take care of. It's sometimes can be burdensome, but if you're willing to do it, the hard work, it's totally worth it. Introduce the sterile fluid into the catheter, into the abdominal cavity, and then it dwells in there for X amount of hours. And it actually, because of its osmolality, it pulls solutes into the peritoneal space into the dialysate. It actually pulls it out because it surrounds the vasculature around your intestines, around your solid organs, around your hollow organs, and it actually sits on the outside of it. And because of the glucose concentrations, the calcium concentrations, and other things, it pulls out those solutes and waste. And it's funny because when you excrete it out of the abdomen, it looks exactly like urine. So, fun facts. We're going to touch on a couple other things real quick as we get ready to close out the chapter. Organ transplants are common. For kidneys, things you want to draw before ever doing any surgery is CBC, CMP, lipid, thyroid, urine analysis, blood type and screen, virology, cancer, absolutely. We're going to do a pulmonary evaluation, nutritional, osteo, dental, US, ultrasound of gallbladder, psych evaluation, financial evaluation. We're doing the whole gambit. Getting an organ is a big, big, big deal. Okay. And in this case, we're referring to it in the sense of the kidneys. Now, things or reasons you would not get a kidney typically fall under you're older than 65, you are completely ventilatory dependent, meaning you can't get off the vent without the kidney. Okay, and even if you could and you can't get off the vent, you're not going to get that kidney. Corticosteroid therapy at high doses? No. Infection? No. BMI greater than 30? I don't like that one because that's a dead lie. I'm not sure why it's even up there. There are people definitely higher than 30 that have gotten kidneys. Associated organ dysfunction? Malignancy, smokers, poor rehab potential, absolutely. And what they should put next to this, and I hate seeing it, for example, is homeless individuals. You'll see homeless individuals fall into the poor rehab potential category because they don't have a support system, they don't have a place to go home to, they don't have clean running water, they don't have good habits, and that's so sad. But it's understandable when you're dealing with something like an organ where it relies on you, being very, very specific about your treatments and adhering to them. So, significant psychosocial problems, substance abuse, history of non adherence to medical therapy, all reasons you would not get an organ. Post transplant, we're going to have to do some immunosuppression. Absolutely. Your body's going to scan it, look at it, be like, I hate you. You're not my. Step Brothers, the movie, perfect example. I hate you. You're a brand new kidney. This is prison on planet body. Anyway, the point is this: your body's not going to like that kidney unless we suppress your immune system. So what do? We do immunosuppression through medication. We go ahead and we give you steroids to decrease inflammation and swelling. Because if you reject that organ and kill it, not only can the organ itself become severely damaged and infected, but graft versus host is a very real thing, and a lot of people don't survive that. So be aware of that. And then lastly is infection. What does rejection look like? Hyperacute humoral mediated response that occurs within hours of a result previous exposure of antigens. Actually, you know what? I'm not going over this. Your body can reject it. Immunosuppression. This I do want you to know. So essentially what we're trying to do is wipe out your T cells, your T killer cells. Okay. We're trying to stabilize the patient and maintain the ability of the body to heal. Because it's going to try and attack it at first. So then on top of it, high doses for acute rejection states of immunosuppression can result in secondary infection. And then we can have what's called desensitization, and that's what we do is we actually desensitize your body from sensing the kidney and forming antibodies to it. So, fun facts. I'm not going through all that. I will show you this because this is actually pretty darn cool. So, kidney transplants. Excuse me. The first successful one was in 1954. Issues in transplantation. 100,000 patients await transplantation a year. That is 100% true. Did you know they do not remove your old kidney and put the new one in place at all? Nope. Actually, they come down to the iliac artery right here and the iliac vein, and they actually come down here and attach it to the vein. So essentially, it's like implanting hemodialysis inside your body. And that's what it does. It's actually really good at it. They actually leave your old diseased kidney in place, or two kidneys if you have both, and they actually will shrivel up over time and just disappear. That's it. They should, well, not disappear. They shrivel up to nothing is what they do. But yeah, your new kidney attached to your iliac vein. Fun fact. What we're going to look at: CVP, weight, vital signs, hypokalemia, hypomagnesemia, hypocalcemia, BUN, creatinine, CBC, urine output Q 30 minutes for a minimum of 24 hours. Absolutely. By the way, the minute this kidney's hooked up to blood, it should start producing urine, like right away. So, fun fact. I'm going to go ahead and touch on this just really quick as we start closing out the chapter finally. Patient education is pretty serious here when it comes to any kind of CKD patient. Um, I will admit there is some degree of taboo and judgment that goes along with CKD patients, and we take this position with, oh, you earned it. Like type 2 diabetics. I have to admit, I am biased. I can't stand type 2 diabetics. We've gone to the ends of the earth to help them. We've come up with all these treatments and formulated all this stuff. And then they go home and they refuse to be compliant. And they continuously come back to the hospital in a dying/critical state. And like, yeah, I don't know what happened. Yeah, yeah. And they're the worst patients. But what we don't stop to consider sometimes is that the patient has some psychological factors that are also influencing their behavior and their decision making and compliance with medication management. So, I mean, we can educate them on dietary and fluid compliance, avoid salt, decrease fluids, avoiding complications, stay clear of, sick people, lifestyle modifications, start exercising, eat better, sleep more, social improvement, you have a reason to live, your family's involvement, etc., support system, etc. So there's reasons we can educate people, but I have to admit, when you start entering into the realm of needing hemodialysis Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, there's a psychological factor and component that goes along with that treatment that causes a lot of stress for the patient. These people, and you don't know where they're coming from, what environments they live in, how things are going. So be aware that there's a psychological component. If you can educate, if you can reach out to them, do so. If you can get on to the in level with them on an emotional level, do so. But essentially, what we're doing is we're looking out and saying, hey, you need to restrict your fluids, you need to restrict your potassium, your sodium, and your phosphate, and maybe they need EPO drugs, so erythropoietin. Maybe they can't make their own red blood cells. Maybe they can't have certain medications due to the fact their kidneys can't clear them. Iodine, for example, and Vanco. Educate your patient on these things because no one else will. Da, da, da. I'll just touch on this real quick. How do you prevent AKI? Real simple. Prevent renal insufficiency, prevent sepsis. You can't prevent elderly, but it is a risk factor. Comorbidities such as liver and cardiac are risk factors, hypertension specifically. But that's chronic, excuse me. Avoid nephrotoxins, exo and endogenous. Monitor hemodynamics. Avoid low blood pressure. Avoid volume depletion. CKD, we're going to go ahead and treat AKI very aggressively up front. We're going to control the hypertension and diabetes, avoid nephrotoxins, endo and exogenous, and monitor renal function in at-risk patients. All right, that brings us to the end of our slideshow for today. Thank you so much for listening. And as always, I will see you guys in class. Hope this helped. You guys all take care.